Welcome. Today we are presenting a webinar with presentations from our GKII scholars, Rose Pollard Kaptchuk and Prakhar Misra. This is the Johns Hopkins Gluck-Teklinski India Institute. We're very excited to feature some of our scholars' work and to have your participation either live or on the Zoom recording. Today's agenda will be a brief welcome and overview about GKII at Johns Hopkins, and we're going to go over some of the things about the award very briefly in the introductions. Then we're going to get into the meat of the presentations by our scholars, Rose, followed by Prakhar, for about 15 minutes or so each. And we do have some guest presenters from India, so we're very excited about that as well. Then we'll close with a synthesis, and we'll offer the opportunity for the attendees that are joining us live to ask questions. During the presentation, please go ahead and use the chat or the Q&A feature in Zoom. And for those watching on the recording, we'll have some information on how you can get in touch with us post-event. So this is a very interesting award because it's very broad. So our presentations today seem somewhat, I think, different in their scope, but I do think there is a common thread here, and it's really about how do we build stronger, more equitable public systems in India. So these research projects really revealed something very similar in their challenge. So Rose's presentation will focus more on the health equity side of healthcare systems. Prakhar's is more on the governance and state capacity side, but I think you'll see some common themes throughout. A little bit about the award and the Institute. The Johns Hopkins Gupta-Klinski India Institute is really designed to support these types of very emerging and innovative research projects. We have extensive connections to India. We are working with many Indian institutions. We've got many faculty working in India from India as well as students. We have our own programs, awards, and these types of events. So we hope that if this is the first time that you're being joined by us, that you stay connected to the Institute, and really as we grow our program, you'll hear more about the things that we're offering. Now, this particular award in the pilot year was founded to offer 2 research grants. So they're very focused on research, and it was really about giving the scholars that you'll see access to be able to travel, funding, support, to be able to really advance their projects. And you'll see in both of the presentations today, they really use that funding well, which I'm very excited about. And this is being supported by generous donors. So thank you to all of the contributors, Dr. Sunil Kumar, Dr. Sumati Murli. These opportunities are really supported by the people that commit to advancing this type of work. So thank you very much for this. All right, so this award, like I said, was given out to 2 scholars who you're going to hear from very shortly, but you'll see they really got a lot done in the past year. Rose had 3 of her aims completed. There were so many surveys conducted as well as workshops. She has papers in the press, conferences being presented, and a design to provide her training course. So a lot was accomplished in just a year. And same with Prakhar. He reached many states with his work. He's piloted new surveys and administrative policies and records. He's got papers in progress, and he's presenting also at conferences. So I hope you'll learn a lot from these scholars and stay connected with their work. So first we'll hear from Rose. Her research project and her study is focused on aligning HIV services with transgender and gender diverse community needs in India. Then we'll hear from Prakhar. His study is focused on governance and state capacity and practice in India, and the recruitment system in the Indian government. So that is all I have. I'm really excited for you to hear from our presenters today, and I'll hand it over to Rose first.
Okay, hi everyone. I am thrilled to be here, thrilled to share our work. My name is Rose Pollard Kaptchuk. I'm now a postdoc at the Johns Hopkins Bloomberg School of Public Health. I'm honored to be joined by my colleagues in India, Vasudevan and Dr. Kanthikiran at YRG, who are really the experts in the room. We are going to be talking about aligning HIV services with transgender and gender diverse community needs in India. And first, to offer some background, by transgender people, we're going to be talking about people whose gender identity differs from society's expectations of the sex assigned to them at birth. And health burdens globally remain high among transgender people, with research documenting especially higher burdens of HIV and mental health challenges. Now, in India, there's a long history of transgender people. There are many examples in prominent ancient mythologies, and they're not true for everyone. Many express fluidity in gender identity and gender expression in varying per context. And similar in places globally, the terms used for identities of gender diverse people in India have a lot of variability and regional variation. And this really matters because with the goal of improving healthcare for transgender populations, all these people may walk into the same clinic, and we want to offer the same care of quality and affirmation across diversity. Now, to look at HIV specifically in India, the general adult prevalence of HIV is estimated to be 0.2%, but this is not distributed equally among all people. And like other countries, some populations have a higher burden. You can see among the populations that the government tracks that transgender people have the second highest prevalence of HIV in India, around 3%. The body of the India's Ministry of Health, who champions public HIV services, is the National AIDS Control Organization. And they implement targeted interventions, or TIs, and there are many TIs which focus on reaching transgender people across India. This model focuses on HIV. So TIs partner with NGOs to try and get as many people who they can contact as possible to come get tested for HIV and offer appropriate referrals for treatment or whatever they need. But the focus remains at TIs on HIV. As an alternative approach, the Accelerate program, which was an initiative led by Johns Hopkins University in partnership with YRG since 2019, piloted an alternative model which put the community needs first and foremost for healthcare for transgender people. These clinics were called Mitra Clinic, and Mitra means friend or ally. The model was designed through community partnership, and the idea was to offer a low resource model that could eventually be transitioned to the public healthcare system with a comprehensive care approach. That means offering services beyond HIV as an access point, hopefully aligned with what communities need and want. And for my dissertation, when I was a PhD student in the International Health Department at Johns Hopkins, we asked, how do we design healthcare which communities want? And is this model of Mitra Clinic really meeting community needs? And to explore this specific question, we conducted interviews with the clients of Mitra Clinic. We did these interviews in 2024 to 2025 in Pune and Thane and Hyderabad. You can see me with the interviewers we partnered with, Tejas and Shamnu in respective locations, who are from Pune and Hyderabad respectively. They conducted the interviews in the local languages of participants. We partnered closely with the staff at Mitra Clinic to recruit a diverse range of identities of clients, as well as a range of exposure to Mitra Clinic. The interviews were audio recorded, and we really had an iterative process for analysis, and we ended up with 27 interviews. And I'm going to share here briefly some findings about healthcare priorities and values. It was really clear from participants that past experiences involved confusion of where to go to even get respectful care. People had worries about their safety and security at healthcare locations. One transgender woman respondent, who was 40 years old, said, "We can't speak about HIV with private doctors. We can't tell them that we want a good chest or female physique. Even today, I don't believe that we receive proper treatment in government hospitals." In contrast, people did feel that the care at Mitra Clinic was different, more welcoming in most cases. A trans woman who was 41 said, "It is more like a home where everything is known to a transgender. I come here with the confidence that we can freely express our problems to doctors and get treatment." People talked about the specific services that they really came to Mitra Clinic for and that they wanted. A big part of that was gender affirming care. Services that Mitra Clinic offered that were really popular included laser hair removal and skin health, and support to access gender affirming hormones or surgeries. People talked about how hard it was to learn about the available options for gender affirming care and learn about differences across different service locations. So having a chance to have education and learning on this aspect was a big piece that people valued at Mitra Clinic. Other clinical needs that people talked about wanting and needing was primary care, chronic disease care, especially for older participants, and transgender men, in contrast to transgender women, talked about their unique needs that they wanted to be represented and provided at Mitra Clinic. And people also access HIV and STI services, although this usually was not a priority for going. And peer exchange was another aspect that people really elevated as a big component for both learning and seeing health behaviors modeled in others at Mitra Clinic. I also really want to emphasize mental health as a component people came to the clinic to access services for. A lot of participants shared past feelings of depression and suicidality. One respondent said that so many transgender people were dying because, quote, they don't have access to counseling. And beyond healthcare itself, people wanted and did access services around structural needs, things like safe housing and legal system navigation. Participants wanted protection from violence specifically and reliable services for safety, support, and post-violence care. A trans man who was 26 years old said that to have a proper shelter, if we have that, we can do any other work and live. That is our happiness. So the services, in summary, that people really emphasized were clinical services, mental health needs, peer exchange, education and learning, and structural services. But what made Mitra Clinic feel special is that all these services were offered in one place and care came together to cover different parts of people's lives. And it was not just about the services people cared about, but how they were delivered. The values people shared in interviews emphasized affordability, respectful and kind interactions, ample time with a provider who was informed about transgender health, and also representation of transgender community. So since we conducted these interviews, the clinics have really evolved. Now they are called sub-rung clinics and run entirely by YRG. And due to the generous research award support from GKII that I received, I was able to continue my work in partnership with the sub-rung clinics. In April, I was there and we were able to conduct workshops focusing on mental health, a big aspect that you saw from the interviews that were really highlighted as a need and a gap in quality service delivery. So we did some creative activities and brainstorming for the clinics on how we can expand those services. And due to the support from GKI, it was so satisfying to me to be able to go back and expand this work to continue the staff collaboration. And I'm excited now to introduce my colleague Vasu to tell you more about the specific sub-rung clinics in operation now. Over to you, Vasu.
Oh, thank you, Rose. Thank you, attendees, and thank you, panelists. So, just to add what Rose was saying, that the sub-rung clinics are basically supported by Tata Trust, except one location, that is Lucknow. The other locations which Rose mentioned are all supported by Tata Trust. It's a CSR funding. So we are able to continue that activity post the Mithru that has happened. And then the uniqueness of this is that the clinics are all run by the community members. And we also focus on the comprehensive packages, precisely the clinical, social, psychological, and legal services associated with them. And then, as Rose mentioned earlier, that the TA model works on more of HIV prevention, whereas the sub-rung clinics offer the holistic care, including laser services, the pre-exposure prophylaxis, post-exposure prophylaxis, and then hormone replacement therapy support, and then also some of the laboratory diagnostic support, which is required for initiating the PrEP or hormone replacement therapy. So we also have networking with the endocrinologists, psychiatrists, and other allied clinical support is offered in these clinics. And we also conduct specialized sessions on services, basically highlighting the services and then also sensitizing for important aspects of treatment and the social benefits in particular. what are the things that is available for transgender community and LGBT community, and then how we will be able to link them to that. So the Pune clinic is the one which is pictured here. So it is a standalone clinic. It is basically run by YRG itself, and then this is located in a place where the LGBT community at large are there, including the transgender hub is there, and then also the female sex workers are available over there. And it has an in-house laboratory, and it also does the basic tests. For example, HIV screening, STI screening, it does, and rest it is actually shipped to either Chennai or it is outsourced, so that the client need not have to go to multiple places. So it is all integrated in one place. Next, when we go to Thane location, that is his next center that we have. It is actually located in a government hospital inside an OPD, that is the outpatient department. So the model is the idea, the thought, and the process are all the same, but only thing is they are located in different locations. And this particular unit, which is there in Thane, supports the preventive and social medicine department of the hospital on community engagement, because we extensively work on community engagement, and the PSM department, which is supposed to do a lot of community work, takes our help. So that's a good connectivity we have, and we have a strong community support of through the NGOs and CBOs who are working for the LGBT community, so that we are able to mobilize the population for that. And this clinic in particular has enrolled about 1,000 through 300 clients, and Pune Center has enrolled about 900 clients. So when we go to the Lucknow location, which is actually a very age old, I can say, because it's the first one rather it started, and it is again a community-based location, and it is a standalone, and it's a youth focus, and youth communities and volunteers extensively they work among the youth in the Lucknow. There is a lot of response among the youth here, and they have enrolled about 1,000 clients approximately. Finally, to the Hyderabad location, this is also a community-based location with standalone space. It is owned by YRG, and it has an in-house pharmacy and in-house laboratory, and it also provides technical assistance to the NGOs and CBOs who are working for the LGBTQ community, and it has enrolled over 2,000 clients, because this has been running for quite some time, and it has been very successful in Hyderabad. So thank you, and over to Dr. Kanti.
Hello everyone. So as Rose and Vasu sir mentioned, so we have moved from being a transgender clinic to a clinic for sexual minorities, providing comprehensive care. But still we face many challenges while providing the services when we want to meet the client needs. So there is always this trust building amongst the clients and the client and provider interaction. So it is still the issues are there, but we are trying to like overcome these. And when it comes to the clients, so majorly they come with multiple needs, not just the clinical and preventive needs. Sometimes they need, as my colleague said, they usually come for legal support, and also they want services related to social protection or with their daily living. So often these needs are very overlapping, and providing them at once or at under one umbrella or at one location, sometimes it's a bit challenging. So as we said, Thane location is inside a medical college hospital, so we have like support from different departments, but it's different for other clinics which are standalone, so we are still facing those challenges. And when it comes to the changes to the recent amendment to the Transgender Act. So earlier we had this Transgender Act, and recently in March we have an amendment. Government has passed an amendment due to which we are uncertain how to provide the gender affirming services, who should be called as a transgender. So there are a couple of questions arising. So we are a bit uncertain about providing these services. And so we have learned there are certain things which are like worked well here, so which gave us a hope that this is a good model. So this is through we, as I said, the building trust is a challenge, but we are overcoming it through using correct pronouns or affirming language, and our most of our staff are part of the community or community friendly. And not just provider driven healthcare, but it's a shared decision making. So we ask the clients also to come and participate or have a consultation and give us input, so that we'll come with a proper solution for each of them. And as we mentioned earlier, so this route is a low barrier entry, rather the historic HIV route. We are providing laser hair removal services or gender affirming care to register more clients, or clients they get registered more in numbers. And also many a times when we take the feedback, or when clients come back and discuss with us, what they usually say is they remember how they were being treated than what treatment they have received from us. So that is a huge thing for us. And also we understood that if we provide that confidentiality and respectful care, there will be more likely to get tested or take prep, or discuss their risky behaviors. And also we work with the community organizations and gurus who are part of the transgender communities, which improved client access, also the retention of these clients for long-term follow-ups. Also our future, so as I said, as we already said, Lucknow team is already working with youth, and in other locations also, and also our online platform, we are trying to reach more youth which are confused right now, or into risky behaviors, or exploring their gender, or still exploring their identity. So we want to provide youth friendly clinic hours or online teleconsultations for them, and improve that our digital outreach through Instagram posts or Facebook, and reach more youth, or provide awareness sessions or competitions which can involve the youth and come and participate and talk more about these, or mental health integration. Also, we want to expand our preventive services to especially the youngsters, providing hepatitis B or HPV vaccination, condoms, STI screening, and PrEP PEP. So we just want to not just providing the services, we want to provide a safe space where they can come and accept the respectful care which they need. So over to you, Rose. Thank you.
Thank you so much, Dr. Kanthi. And just to end, we'll emphasize that clients are really seeking humanity, that the value of these clinics, like Dr. Kanthi said, is about how they're treated. A trans woman in our interviews who is 29 says that everyone faces problems, but what I would say is that trans people face it differently. Regardless of the problems we face, we have to fight for our livelihood. We are also humans. So we'll end with that. Thank you everyone for listening, and we look forward to your questions.
Thank you all so much for that presentation. The impact you're having in people's lives through this work is just outstanding and, just incredible. So that was really inspiring to hear, just from the community perspective. Thank you. We do have a question in the chat, but we'll go on to Prakhar, his presentation, and we'll address the questions after he presents his work. Thank you. Prakhar, are you able to share your screen? There we go. We can see it now. Thank you.
Just gonna, yeah, is this visible?
It's starting right now. So
It's not sharing. Just a second.
that's okay. Why don't we go ahead and ask that question? There was a question right here about, can you provide more insights into what factors drive site selection as Sabrang expands? Perhaps just briefly in a minute, respond to that, and then we'll allow Prakhar to begin his presentation. Rose?
Certainly. I'll just share that YRG is certainly exploring the success of these different models, which Vasu shared, and I think the current experiences will inform choices for next sites if we expand. Vasu, do you want to add anything else to that?
Oh, yeah. So basically, the sites have been selected more on the presence of the community. Number one. The second thing is that the needs that are falling in. And as Rose was mentioning in her qualitative, there is a lot more things came up. But in fact, if you quantify it, these are the locations that have been selected where there is a high requirement is there, and that's why these locations have been chosen. And also, the service needs is very high in these locations. So I hope this answers the question.
Yes.
Thank you.
Thank you. Thank you very much. Over to you, Prakhar.
Can you confirm if you can see this?
We can.
Perfect. Thanks, everyone. Thank you for joining. My presentation is going to be slightly different from the previous one, slightly more academic. My interests are in state building and how the administrative state or the bureaucracy sort of operates. Given that I think that is what the mechanism for welfare delivery is. And what I'm really going to do is walk through what the project is, talk very briefly about fieldwork, talk to you about some of my findings around compliance burdens, and then if we have time, brush over some of the contractual stuff. So the question that I'm really after is it's preambled on three parts, which is India has a very small bureaucracy. There is credible political intent to recruit, and there is a high demand for government jobs. Yet, why does the Indian state fail to recruit public sector employees? And the protests that are going on right now makes this question very, very relevant. Even though I've been working on this for a couple of years now, it's really sort of even on ground as I go, I see why what's happening. So my broad answer, what I'm coming up with, is that there is a new stable form of employment that's being generated within the bureaucracy called the permanent temporary, where an employee is formally temporary, so they'll be on contract or an outsourced employee, but functionally they do everything that a permanent employee does. And you see this at all levels. And this is largely happening when the government meets some sort of a permanence trap, which is to say that channels of recruitment of permanent employees are blocked, and no one reform can really fix it. And second is when there's an alternative that's available, which in this case is contractual employment. The central government, as well as many other state governments, have been trying to, for almost, I think about 15 years now, they've been trying to outsource a lot of the aspects, and that's what's going on here. In this presentation, I won't be able to go through the full argument, but I'll largely talk about the permanence trap and show you why fixing the recruitment process is hard. So the way I'll go about this is give you some evidence for India being a small bureaucracy, there being political intent to recruit, which I want to convince you that there is, and then, of course, that the demand for jobs is high, and then tell you about compliance burdens and where that trap really comes from. So to put stuff into perspective, how small is the Indian state? We have about 16 public employees per 1,000 people. Norway is 159. US, which is 77. And I've taken this from Karthik Muralidharan's book, where he writes US is a market-driven economy, and still it is 5 times more than India. So we're more welfareist, and therefore, I mean, we're that small. But that's the international comparison. Even domestically, and I have too many numbers here, but I want you to focus on this last column, where the percent of vacant posts in the central government has been steadily increasing over the past decade or so. And it's almost a quarter of sanctioned posts, which is about 25%. So out of 4 million, about 10 lakh posts, so 900,000 posts are empty, and that's an alarming number. Similarly, at the state level, so this is Uttar Pradesh, very high population, difficult to govern, low per capita income. And again, you see that about 35% of the state posts are vacant, right? So out of 12 lakh, 4.5 lakh posts are vacant. This is across the state, all levels, everything, police, teachers, healthcare, everything, right? So 35% is vacant, and you wonder, okay, maybe it's a large state and they can't do it well. And then you go look at Karnataka, much higher per capita income, much smaller, and there's a similar trend, right? So they still have 35% seats vacant. So why is this happening? It could be that politicians just don't want to recruit, or it could be that people just don't want these jobs, and we want to get that out of the way. So there's a lot I have on political intent to recruit, but I'll keep this section short because I think the CJP protests, even if there wasn't intent to recruit, I think there is now. So this is the Congress announcement that they put out in 2024, where they gave you a breakdown of the number of posts and the number of ministries that they would actually hire if they're voted into power. Similarly, the BJP government announced almost 1 million jobs and to sort of go over that in 18 months. And they ended up doing a tenth of that, but even that is a lot in 18 months' time. And there are lots of announcements at state level as well, but I don't want to belabor the point. So there is labor demand, which is recruitment within government. In terms of labor supply, this is data on demand for government jobs at the center. And you see, and the very last row is what I want you to see, which is in 2021, about 3 million candidates applied for the UPSC exams, out of which 3,500 were selected, right? And the percent successful, this rate is steadily declining over since 1950. So clearly there is a lot more demand here. And this extends itself even at the state level, which is, again, the number of candidates appearing, this is across 26 states, is about 11.8 million in 2022. And the number of candidates recommended was just 60,000, right? So if you are one of the 11.8 million, your chances of being successful are very, very low. Yet people are doing this and appearing for government exams. From everything from Army, Navy, Air Force, bank, PO. I mean, there's all sorts of stuff going on. So what's really going on? And what I really did was try to focus on why is subnational recruitment so low. And the idea here is that it's around the process of recruitment. And to understand what's really going on, what I really did was conduct interviews. About 100 bureaucrats or administrative officers across 7 different states. 80% broadly of my interviews were at state public service commissions, which is the nodal recruiting body in most states. It's equivalent to the Union Public Service Commission, which is what we're more familiar with. And about 20% there are other recruitment boards, police recruitment board, teacher recruitment board, medical services recruitment board. Tamil Nadu has a uniformed services recruitment board, which recruits everybody who wears a uniform. So that's what I did. That's the broad breakdown of the number of interviews I was able to conduct, etc. And what the fundamental finding here, or one part of the fundamental finding, is that there are high compliance burdens on the process of recruitment itself. And that's what derails very systemically state building in India. So what's really going on, right? What is compliance burden? That the amount of resources that you spend complying with a particular rule is what you think of as compliance burdens. And this really comes from the red tape literature. And we're broadly familiar with the idea of red tape, but to put it down, it rests on the presumption that everybody is entitled to equal treatment. And therefore you need rules, regulations, procedures, processes, so that there's no favoritism. But often those rules stop serving their functional purpose. So that becomes rule evolved red tape. And you see that within the idea of operationalizing meritocracy in public sector recruitment, right? Which has 3 dimensions to it. One, that the system should have qualifications, the people should be competent, and most important, there should be absence of political favoritism. And that's what I would argue we're trying to overly correct for. And so we codify selection rules for people to come into government, and that codification process itself is what creates distortions in the hiring or the recruitment thing, right? So I argue that it creates a permanence trap. And which is what I was saying earlier, that the recruitment becomes multiply block, that no one reform can really fix the process. And I want to show you evidence for this through the examination process itself. So what does it take for the state or for the government to hire an employee at the state level? And through my interviews, I've divided this into like 7 stages, the whole recruitment process. I want to walk you through that to sort of make the point, and that's the crux of this presentation. And then I can just end with showing you some data. So what's really going on? So first, stage 1 is where a department has to issue an indent to the State Public Service Commission, which is who recruits. So think of it like the agricultural department saying we want to hire 3 experts in XYZ field. They'll draft the intent and they'll send it to the Public Service Commission. Before they draft the intent, they're discussing a lot of this with the Service Commission, with the finance, with the general administrative department. So after all of that, you've decided that you want, let's say, 3 electrical electrical engineers to fix your irrigation system or to fix your power system, right? These indents have these details: post qualifications, relaxations, disability allowances, and skills and competencies. And after receiving the indents, the PSC waits to meet a certain threshold, because for every post, there are going to be lots of people who are going to apply. So the PSC is also limited in its capacity. It cannot just go and keep conducting exams for, even like, if somebody wants to hire one junior engineer, it's not going to do that. So it's going to sit and wait and going to put out a notification for multiple posts together. And that's when it puts the notification that notifies a syllabus and prepares it with the technical agency. Now, the notification is not exactly just like a page. It's a really long 25-page document. And there are generally three characteristics that I've noticed from my work. One, they're very precise, right? So they tell you minimum height must not be less than 165 centimeters. Maximum must not be that. What your chest should be on full inspiration, etc. And this is for, I think I've picked this up from the traffic inspector for Andhra Pradesh, if I'm not wrong. Second characteristic is that they have caveats and relaxations. So, for instance, they must have a motor driving license for a period not less than 3 years and a heavy transport vehicles endorsement. That's quite clear. But then if 3 years is not available, person with 2 years is okay. If you're a woman, then you must hold a motor driving license. But if you have a light motor driving license, that's okay. You can acquire the heavy within 2 years. So they do a lot of this stuff, which increases the compliances that is built on them, and they don't have the capacity to then sort of comply for this. And finally, there's a criteria where candidates with decayed teeth shall be deemed disqualified. It was interesting for me to see this. I want to say that I'm putting it out there because I saw it, but this is not a repetitive pattern per se. But you do have arbitrary criteria within these notifications, and you're wondering, why is this even there? But that's stage 2, right? So the notification is issued, the advertisement is put out, and then you got to conduct exams. And the questions are, they literally have a super secret, like in Uttarakhand, they call it Gopan and Ati Gopan departments, which is secret and super secret, where they solicit questions from empaneled experts. And then they have to identify exam centers. And by the way, these are like literally strong rooms, jail cells. I was entering one of them, and suddenly there were security guards who came in with guns, and they're like, you can't enter there and all of that. So it's like very heavily guarded stuff. They then have to identify exam centers where they have to coordinate with district magistrates, chief education officer, the block education officer, etc. Then you have to evaluate the centers on multiple grounds so that people can actually reach it. And then there are some physical field visits that they're undertaken, etc. And they have these rules that are baked in to ensure fairness in some sense across different rules. So 24 students per class, 20 rooms per center. The workload differs. So for one of the exams, they had to go across 70 districts in UP for about 1 million candidates. For another in UP, across 5 districts, 150,000 candidates. But that's the workload on identifying the centers. And then you have to transport the exam papers, which is a big thing. Papers are locked with 2 locks. They're stored in the district treasury. The office is open 2 hours before the exams. There are 5 officials who are designated. 2 will have keys. So a lot of redundancies and randomization that's built in. And then there's administering the exams, where the DM arranges meetings, and the supervisors are trained. A sector magistrate is appointed. Sealed question papers are taken out with the certificate of authentication, etc. And despite all this, papers get leaked left, right, and center. So clearly something's broken. They're not able to comply here with these rules. Then they got a call for objections on the paper, which is to say that if there is a particular answer that is incorrectly printed, they want to nullify that question in some sense, or the translation of certain papers is not right. And one of the exams in UP, they received 67,000 objections, and they got to go and sort of sit and resolve that. And then a committee is appointed to resolve and evaluate these objections. Finally, they issue a merit list. And here, reservation criteria plays a big role in how they allot. And there's vertical and horizontal reservation, and that has to sort of intersect. So you have to be a SC, ST, OBC, and then sort of, there is horizontal reservations. Acid attack victims, for example. So then some positions are only for an SC acid attack victim. And they're able to figure that out. So the figuring of the position out is not that much of a problem, as much as finding that candidate for that particular position is through the roster point system that they do. And this is not to say that the criteria itself is wrong. This is to say that they probably don't have the capacity to do it. So they don't have enough people on ground to do this at all. Finally, they have to verify documents. How do you verify these documents? Caste certificates, education certificates. Who verifies them is the determining factor, and that happens through when ranks of authorities are sort of specified, and this is what that specification really looks like, right? Like according to such and such government order, or such and such welfare department will be excluding these categories from these particular documents. Or there is litigation in courts where they say that because of such and such litigation, the verification itself will be done by the district magistrate instead of the patwari or whatever. That's how they sort of run it. And if you can't verify it properly, then you have to resubmit the documents, and a replacement list is then generated. And finally, these candidates are then appointed when the dossier of documents is handed to the department. So that's the process of examination. From Andhra Pradesh, I was able to look at these stages and calculate the number of days in each of the stages. And you see that in 2003-04, the average duration was about 238 days, which in 2017-18 moved to about 604 days. So you see that there is a delay that's happening in selection of permanent employees. And I'm arguing that it is this sort of this complicated process that is really leading to that. So that's basically the crux of things. What's really going on, and this is the final three charts here, is I would argue that there is contractual recruitment that's happening. So in the federal government, which is the central government here, in 2016, there were less than 1 million people on contract, which is now increased to about 3.43 million. This is in the central sphere, so this includes PSUs, etc. But you also see this at the state level. So in Andhra Pradesh, you had about 77,000 people on contract, which is increased to 106,000 in 2024. And finally, this is school teachers in India. So contract teachers, you want to see this, which is less than 10% in 2008, has increased to about 22% in 2023. And it dilly-dallies. I mean, you see that it increases and then it drops slightly, etc. But there is a trend that it's largely moving upwards. And so I would argue that the recruitment process in India is made complicated because you're trying to enforce an idea of meritocracy, but you're not building institutions with enough capacity to enforce that idea. And so, like work still has to get done. You still have to show welfare on ground, etc. And that is something that is, that is something that's crippling state building right now, or kind of changing it. I think that's about it. Thank you.
Thank you, Prakhar. Amazing. So illuminating. Have you walk us through that process? I've read both Rose and Prakhar's papers and reports, and both of their presentations just really brought their work to life. I hope that all the participants had that feeling as well. I think we had some comments in the chat to Rose's and colleagues' presentation about it being excellent insight into community engagement, and that's true. It's really you showed what it's like from the community perspective, the individual perspective. And to Prakhar, there was a comment that what you did was a fantastic exercise and a much needed for the country and a great eye opener for the public. So congratulations to both of you. And so we do have some questions. This is a great time for those that are joining us live to actually get involved and engage. And I'll just go to the synthesis slide very quickly, and then we'll take some questions. So I think really what this boils down to in the diverse presentations we had today, it's really about that impact, that local knowledge becoming evidence and having change happen from the ground up. So I would like to offer the opportunity. We have some questions in the chat. Perhaps Kunal can read those and we can, go through some of those for both Rose and Prakhar.
Sure.
Why don't you?
Me
Thank
too.
you.
And thank you both for fantastic presentations. I think real testament to some great work. Thank you for the interest in chat. So we have a number of questions and more are coming in. So let's try and have quick responses. We'll start with for Prakhar. Do these departments simply manage without those employees if recruitment is delayed, or do you see government finding alternative ways to fill the gap? Is the temporary hiring the primary way?
Thanks. Yeah. Yeah. So the temporary hiring is the primary way. Otherwise, I mean, you see so it depends on at what level of government. At the top levels, you will see the same IAS officer holding multiple portfolios. As we saw with the change of the education minister, for example, he now has three very important ministries onto him. That's what gets reflected down within the bureaucracy as well. At the bottom levels, it is largely contractualization and and temporary employees. That's how they basically manage it.
Okay, fantastic. We'll go to Sarah Bennett, our who's in the chat. Thank you, Sarah. Contract workers are also much less costly than permanent government employees. To what extent is that assumption true, firstly, and then is that a factor?
Absolutely true. To what extent is a factor is my policy brain says a large extent. My academic brain is still trying to figure out how do I isolate these these different things. So I don't want to make any big claims. The fiscal side certainly amplifies this shift towards contractualization because the state's fiscal health is in shambles. On average, about 55% of the state budgets are already committed to salaries, interest payments, pensions. So they're left with very little. I mean, states like Kerala are as high as 80 or 85%. So fiscal definitely plays a role. Whether it directly impacts this transition and in what ways, above my pay grade right now, but I'm hoping to get these answers soon.
Great, thank you. And then one more for Sarah. Contract workers are seen as, quote, lower class, quote, bureaucratic officials. To what extent do you think that problematic hierarchy can be addressed?
So they're seen as lower class. I'm not sure of that entirely. So in some cases they definitely are. If you go to like a district office, you will have a data entry operator, a DEO, which is generally on contract, and a junior magistrate whose work is to enter the data like officially will basically just rely on the DEO's work, and the DEO will then and will then just give to the junior magistrate and they'll do it. So there is a sense that sure, one is a permanent employee, one is a contractual employee, but there is one person who's doing all the work, and by that they derive power, so to speak, within the setup. So their interactions is slightly unclear on where the class sort of hierarchy stands. But it's all changing. I mean, they're being a lot more accepted, and they're being a lot more very much a part of the system, integrated, if you may.
Great. We'll do one more for you, Prakhar, then we'll go over to so a couple of questions here along a similar theme. You've mentioned this is a complex problem to solve with many moving parts. But give us some hope for the folks in the room. Do you see a couple of lower hanging fruit changes, perhaps solutions that are in view or maybe resonated in your discussion with bureaucrats that can be implemented?
Yeah, sure. In fact, I'm working with some of the state governments to implement some of this stuff. The big thing is to strengthen the process of contractualization itself, in some sense. I don't think the idea here is to try and get everybody to be a permanent employee. I mean, the pay commissions and the salaries, the public wage premiums just don't allow for that. So what you really want to do is a clean way in which, if Kunal wants to hire Prakhar, it is because Prakhar is meritorious and not because Prakhar is whatever related to Kunal in some way or is giving him a kickback. So I think that's where everything comes through. I am super bullish and very, very positive on the way India is moving right now. I mean, the current government in the last maybe 5 or 7 years has introduced the GEM platform, the government e-marketplace that kind of institutionalizes reverse auctions and bidding. And I'm studying that and happy to speak about that. But that's the kind of stuff that's going on, and that's the direction in which we're moving. The permanent hiring process, there are very simple fixes that these guys are realizing. Simply put out, and this is at the state level, not at the national level, put out like a steady government job calendar, make sure that the public service commissions are are time bound in certain things. Simple things like in the constitution, a public service commission is supposed to put out an annual report. Are they even putting out these annual reports? And enforcing those things are really the tweaks on the margins. But the big thing is, how do you formalize the contractual process?
Great. Thank you so much, Prakhar. We'll go to Rose and maybe come back to you depending on. So, Rose, for you and the YRG team, to what extent did your research distinguish between different types of gender minorities, trans women, trans men, gender fluid persons? To what extent do different needs emerge between these groups, and how do you account for it?
Yeah, that's a great question. I'll respond specifically to my research, and then can ask Dr. Kanthi to reflect on this in the current sub-rung clinics. So in our interviews, we intentionally recruited a diverse range of gender identities. Now that still resulted in the majority being trans women, which does reflect populations in India. But the trans men we spoke to did have different health needs. Specifically, they wanted gynecologic care at their healthcare clinics. Trans men we talked to had been pregnant before, and body-wise, those health needs require different specialties. And providers who are aware of the anatomy of the patients they are seeing and can also approach that relationship to body and anatomy in really respectful ways. That is a combination of expertise that is often not present at most healthcare places for transgender people. It is a area that Mitra Clinic and now Sebrung clinics are really trying to achieve. So that diverse needs of healthcare is really present. Also among trans women we spoke to are trans feminine, gender fluid people. The group of sex workers or those engaged in sex work definitely spoke of experiences of violence and wanted care after violence, wanted more security to ensure their well-being in times of being at physical risk. I'll also point out that gender fluid participants we spoke to often differed their gender expression with family sometimes, especially younger participants versus in other contexts. And so considering family dynamics and having the clinic be a place to support family relationships is another way to support well-being and health. Yeah, Basu, over to you and Dr. Kanthi if you have any other reflections.
Oh, yeah. So very quickly. So the thing is that even though all these formulations are existing in our country, unfortunately, what happens is that they are not able to implement because the community structure is very different and strong. So this is very nicely which has come up in the needs that are put forward by the community. So the point here is that even though there are laws are there, even though there are a lot of regulations have come in very recently, but still the community is very different. It is taking time to adjust to those needs. There is a protection by way of law and the amendments that has come, but still it is not fully supporting them. There's a lot to be done at the ground level and the community level. And that's a great work, which is, still I can say more than 60 to 70% unfinished. Thank you.
Thank you. Another question for you, Rose and team. Is there a risk that providing specialized health facilities for specific kinds of community can encourage marginalization, or how do you protect against that?
Yeah, really nuanced question. And it is true, marginalization is pushing specific groups farther away from society. Ideally, I think public sector would really have better training for providers at all health facilities, ideally, or even, specialized clinics at government hospitals with providers who are really trained in transgender healthcare. I think that can work to combat the marginalization. The reality is we're not there yet. So how do we support people's health and well-being in the meantime to the best of our abilities? There's gaps to be filled. And I think that speaks to how transgender specific clinics operate and are promoted. I think there's differing approaches, whether to really market a clinic as LGBTQ welcoming and affirming, that may be stigmatizing for people who don't want to be associated with the LGBTQ community. People are in different places and spaces. And I think, a range of approaches is a likely the best way to cater to people in what they are ready for. I think in our interviews, especially, just perceptions of people you trust, friends or peers or gurus, maybe family members, and where they have been in the past and their experience, and then telling you as a client can really influence whether you go somewhere. And the environment in a clinic can really affect how marginalized someone feels, if they feel like it is their place when they walk inside or it is not for them. But I think there's really interesting questions around service design and asking communities what they want, and their experience with different approaches really can determine how we best match the community's needs and experiences with the design of services. Dr. Kanthi, do you want to add anything about this potential
Yeah.
marginalization?
Yes. So, like the treatment of the way transgender people or people from the sexual minorities are being treated differently than others, which we know. But as the question says, we are providing specialized clinics or spaces for them. We are encouraging the marginalization more. No. So we are also trying to the one model which we have. We are in a government hospital setup. So there our services are like preventive services as well as the treatment STA care we are providing in our clinic, but for the general consultation we are sending them to the general OPD. But the only difference here is we are accompanying or navigating them from the clinic to the hospital, so that we are trying to so whenever a transgender person walks into a hospital in a government setup, so people have a different look and look them top to bottom, and that is like very uncomfortable for them. So here we are trying to navigate through this crowd and taking them and presenting them to the physicians or surgeons there. So we are not marginalized, we are trying to include them into the existing system, and also we are trying to have dialogue with the providers separately, because the doctors also change their residencies for 1 year or 2 years, so the keep on the providers are changing. So we have regular dialogues with these doctors to how to we want them to talk to the clients respectfully or treat them. So we are trying to include them into the society, not marginalizing by establishing these clinics. So if that is what the question, I think.
Yeah, it's fantastic. Thank you so much. Really, really great responses. Back to you, Prakhar. We have some more questions. So we have Nagesh who asks, is there like a gold standard for the percentage of contractual workers that you have in mind? Because he gives the example that the US government has 862,000 workers at will. When they were at USAID, they estimate that for every direct hire, there were 5 to 10
Thanks for the hard question. um, it's the answer to that is not straightforward, and that's not because I'm copping out. The thing is that so the government setup is tricky because in the public realm, there is, so for instance, garbage collection is a state function, but you don't need to have a deliberative relationship with a state employee. It's okay for somebody to come and collect garbage. Public doctor, on the other hand, is somewhere, I mean, there's somebody who's entering the private space of a patient, but you also need a certain technical sort of knowledge. Tax collection is a completely statutory sort of state responsibility. So across different functions in a state, the contractual percentage would perhaps matter, right? In some aspects, it can be big, in some aspects, it can be low. I don't have an answer to a number. I'm also very underqualified for that right now. But the point I'm trying to make is I'm not sure if it's helpful to think of cutoffs that are acceptable. I think we need a larger theory to inform this before we can start being empirically precise. That's the way I would look at it.
Fantastic.
Thank
And I
you.
know we have to wrap up. Maybe we have one more question, Beth, because certainly there's more questions than we're able to answer today.
Yes, we need to
Prakhar,
wrap
Rose,
up, unfortunately, now with 1
if you're
minute
okay with it,
left.
maybe you could put in your contact details
Yes,
in the chat, and then folks can reach out to you directly.
yes.
But one last,
What we'll
can we
do,
do one last
Kunal,
quick one, or should we wrap up?
I think we need to wrap up. There's only
Okay,
there's 1 minute left. So actually we're at
sounds good.
11 around time. So thank you for helping facilitate that. And for all of the participants, active engagement, the amazing questions in the chat. Please know that we are going to be providing this webinar recording, as well as you can see there's some links to some articles that we've done previously with the presenters today. But our wonderful comms team, communications team, will also be taking some of these questions that perhaps didn't have time to get answered today, and we can perhaps include those in future recaps and interviews as you'll be staying tuned in our newsletter. Please connect and stay connected with GKII at Johns Hopkins. We are so grateful for the community engagement that we've had today at today's webinar, and to really spread the word about the work that we're doing, to connect with us. Our email is there, our website is there. So thank you again, everyone who participated live, who is watching this recording, for joining us today, and to our presenters for their amazing work in the field.
Thank you all. Have a great day and a good evening.
Thank you so much.
Thank you so much, all of you. Thanks for the participation.